Alright, hello and welcome. I'm on my little filming and training map, which I just finished making. Not the map, just placing some assets around base here for eventually a flight video I'm going to film, and these are just arsenals and some presentation tables. But yeah, today we're going to be covering medic training, titled here in the document SARC. That stands for Special Amphibious Reconnaissance Corpsman. It is basically a Navy medic. That's just what my unit calls it. Yours may call it something else, but yeah, that's what we're going to go over. So before I jump into that, I just want to have a few caveats here. We are not going to be covering kidney function. I'm going to assume either you have that turned off or you're allowed to use plasma. We are not going to be covering surgery because, in my opinion, that is not something a medic necessarily does. We are going to be covering CAT and ACE, both ACE, all the ACE systems really, and CAT we're going to be covering airway stuff. Pneumothoraxes, including diagnosing with a stethoscope, which is the way my unit does it. Let me see if there's anything else here that is important that we are going to be covering or not going to be covering. Oh yeah, we're not going to be covering advanced surgical or IV pain-killing drugs, so that's not going to be in the agenda for today. So just morphine, adenosine, and the painkiller boxes. So with that all said, there will be a cut here if I remember anything else that needs to be said before the video, but otherwise we can hop right into it. So if we scroll down here, this is assuming you have zero experience with ACE or CAT, or at least to start with here. So this is an image of the medical menu. If I press H in game, which is my key binding, it brings up the same menu. You can find that under Configure Controls, Configure Add-ons, and then ACE Common, and then Open Medical Menu. That's your key. The other way to access that, if your server or whatever doesn't like that, or to access the medical stuff, is to go to Medical and then just select which limb you're treating with your self-interact keybinds. Or if I spawn myself a guy here with the normal interact keybinds, you just go to medical menu, or you can go to each area to treat as you see fit. So what I'm going to show you to practice, the way you want to do it when you are solo, is come into Eden and give yourself a little practice area like this where you have Zeus. And the most important thing is just go to your loadouts and give a random AI the same loadout as you're using. And then you're going to be working on your actual player character. The reason for this is because in game there are settings that are different from, you know, they're just different from the players to the AI. So for example, if you shoot an AI in the head, they'll drop dead instantly. Whereas if you do that to a player, depending on your settings, they may go unconscious and have 0 heart rate, that kind of stuff. So it's just better to remote control an AI and do all the treating to yourself that way. Additionally, what you should do is go onto your unit server, go to add-on options, and go to server, and then export. And once you come into your own thing, just import that in. So if I do here, copy to clipboard and then import and put it in and hit OK, then that'll copy all the medical settings that are relevant for you. Yeah, I think that's it. So let's hop in. So as you can see in the medical menu here, in the red box, that's the name of your patient. In the orange box, that's examine. In the yellow, that's bandaging. In green, that's medication. That's airway management, advanced treatments, drag/carry, toggling yourself / you're like a different person. So if I press H while looking at myself here, I can switch it between myself, Luke Turner in this case is the AI I'm controlling, or the person I'm looking at. This area here shows you the treatment options based on where you have clicked on the body and what tab you're in. This is your status overview, so it'll show you if they're bleeding or, you know, if they have shrapnel injuries on the body part you've selected. Activity log shows what treatments were rendered and at what time. Quick view, if you attach a pulse oximeter to someone, that's where that'll show up and constantly update. So if we scroll down here, this is our vitals. Every player in the game starts with 80 heart rate, 120/80 blood pressure, and 100% oxygen saturation. So if we go ahead and look at this blood pressure chart, I should be able to zoom. Yeah, here we go. So this is a blood pressure chart that I've made. This was tested in-game by me, so there might be some inaccuracies because it was tested in-game, but you know, it's probably more accurate than some other guides you've seen. So the chart is in the systolic blood pressure, which is the top reading. So 120 is the only reading we care about. In ACE and KAT, it's impossible for the systolic and the diastolic numbers to separate like they would IRL with some medical scenarios. So you really only care about one of the numbers. I chose the systolic just because I don't know, it's the top one. And so if we go ahead and look, the starting is at 120. Ideal shows between about 145 and 75. And then if you exceed 35 or 280, you immediately go into cardiac arrest. And as you can see here, saline, blood, or plasma is what you use to bring blood pressure back, precluding the use of any drugs. Next we have blood. So normal person spawns with 6 liters of blood, and anything below that will show you some blood, and that shows you 5.1 liters. So what that means for us practically is if I shoot myself in the leg here and bandage it, I should have put the faster bandaging mod on. This is going to be annoying. Now that we've bandaged, you can see we've lost some blood, and the blood packs, once you establish an IV, if you have your servers set up that way, the blood packs come in. I need to assign myself as a medic. The blood packs come in 1,000 milliliters, so 1,000 milliliters is a liter. 500 milliliters is half a liter. So generally when someone has lost some blood, that means it's appropriate to put 500 milliliters in somebody. If they have lost more than that, which is a lot of blood or large blood loss or fatal blood, you're always going to want to hit 1,000 milliliters. In my opinion, 250 milliliter bags are just irrelevant to carry. It doesn't matter if you go slightly over the amount of liters in the body. Next we have O2. Now these numbers can change based on what server you're playing on and what you know, what settings they have set up, so be aware of that. But generally a stable O2 is above 85. You go directly into unconsciousness if you get below 75. It becomes lethal at below 65. And cyanosis is a way of diagnosing O2 status without a pulse oximeter. So if we select my arm and we go to examine patient, we can check cyanosis, and because my airway is fine, we're going to see there's no cyanosis present. So we can see what values those are and what they'll show when you check cyanosis. So if you check cyanosis on someone and it shows severe cyanosis, that means you probably got to start bag valving them, or they're going to die on you. And we'll talk about that in a little bit. There's the pH stuff. We're going to skip it because we don't use that. At the moment, we don't teach that in my group, and in my opinion, carrying plasma, it's just, you know, just carry plasma, guys. I mean, if you want to do saline, you can, but it's just annoying. Here we go with the heart rate chart. So starting at 80, ideal is about where it becomes curable. So what that means is in-game, if you've been shot or you've been given excessive drugs or something like that, you will hear your heart rate. An example of this is if you get morphine bombed, you'll hear your heart rate become loud before you pass out. and that happens around below 60 and above 155. Cardiac arrest happens immediately below 35 and above 215. So those are the numbers to keep in mind. If we scroll down to some miscellaneous data, cardiac arrest time is 5 minutes on our server. That means you can be in cardiac arrest for 5 minutes. Assuming your blood and your O2 is dealt with, you will be fine for cardiac arrest in that amount of time. That changes for every server out there. So, you know, just to take a look at your settings if you know how to do that, or ask your admin or medic lead or whoever's in charge of that. Let's go ahead and zoom out. So this is the recommended equipment that I have put out if you are able to carry said equipment in your group. Ignore the saline, change that to plasma. If your pH is turned off, your blood pH, then it doesn't matter, but I always like to carry plasma just in case the settings mess up or whatever. So you can have a look at this and copy a kit. We're not going to talk about it just a second. That's in the next section. But this is what you should generally carry. So if we scroll down to the equipment table, this goes over all the advanced stuff. So let's go down the list. The bag valve mask plus a 150 liter O2 tank. This slows O2 loss / increases O2 recovery, but the throat must be clear to use it. Next is adenosine. This is an auto injector, so you stab it into someone, no IV required. It decreases the heart rate and decreases blood pressure. This acts for about 2 minutes, and you can give about 3 of them on a person with the starting heart rate. If we go ahead and have a look at our test values here, here's a little chart of a test we did in game, averaged out about 5 times. So starting heart rate, drug is injected. Over the course of 20 seconds, you drop down about 20 heart rate. And then over the course of the next 100 seconds, you climb back up to your starting heart rate there. So this is what the heart rate when plotted looks like with adenosine use. And that'll come into effect later when we talk about different drug cocktails that you can use to get different desired effects. Epinephrine, this increases heart rate, it increases blood pressure, it increases the wake-up chance, which we'll talk about in a second here. It increases the chance of CPR success, and that's it. So if we have a look at epinephrine, this is what it does to your heart rate. It's almost exactly the opposite of adenosine. We start at 80, injected over the course of about 20 seconds, about 15 for epi, you gain about 20 heart rate. So it's roughly the same, and then over the course of the next 100 seconds, it drops back down. So that's what epinephrine does to a patient in the heart rate. Next we have painkiller. Those are the box painkillers. Slight increase to heart rate, slight increase to blood pressure. These are negligible, and there are 10 of those per box. You can spam these. It would be impossible to overdose someone on these in a realistic fashion. So yeah, hand them out like they're candy, basically. Naloxone is used in case of a morphine overdose. So if your unit uses morphine, you're going to want to carry naloxone. It is 1 usage per morphine, and all that'll do is clear the morphine out of the system. If they've gone into cardiac arrest, you're still going to need to go through a cardiac arrest procedure to bring them back. But naloxone is how you get rid of the morphine. TXA, it acts as a body-wide quick clot bandage, which applies every 6 seconds for 120 seconds. Normally, we advise not to use it, not to use more than one every 10 minutes. EACA, this is an automatic stitching drug and encourages blood clots, basically. That's my understanding of it. It's like quick clot, but in drug form. And it applies an automatic stitching action that applies a single stitch every 6 seconds till every wound is stitched. These 2 drugs are your miracle drugs. If you're allowed to use them, you should carry numerous amounts of these. you can use these, especially during mass casualty events. You run around to each patient in the mass casualty and administer this, and after a little bit, all your patients will have their bleeding passively being treated. So it's very valuable for that. Carbonate, this wakes a patient up between blood pressure of 110 and 130. It's pretty useful. I don't find myself using it that much. We have the reorientation slap turned on, which we'll talk about in a second. Here's the surgical kit. So that is surgery. You just, here I can demonstrate. You just use surgical kit, it stitches, and the wound disappears. This also on some servers allows the patient to walk properly again. Some servers have it where if you get shot in the legs, you need stitching before you can walk properly. 16 gauge IV. This is used on the limbs to administer fluids and vial drugs. Vial meaning they are in a little ampule, not their vial is an evil. Fast IO is equivalent to the 16 gauge IV, as in it has the same flow rate. It is used exclusively on the chest, and if you use it on a conscious patient, you might find them being unconscious quite quickly. And that is because IRL, the way these work is you drill into the bone and you attach it in there, and I'm sure you can imagine that is very painful. So in Arma, it's simulated with quite a bit of pain. The stethoscope is used to diagnose tension, pneumothorax, and hemothorax. We'll talk about that later. The AccuVac removes occlusion from the throat. The chest seal / AAT kit are your treatment options for the pneumothorax and hemothorax. The AEDX and the AED at this point can be used to, well, actually, let's talk about it separately. The AEDX can be attached to monitor heart rate, blood pressure, and I think O2? I don't know. Maybe O2, but just carry pulse oxes. It'll advise if a shock is required. If it is required, you manually initiate that shock to the patient to restore heart rate. The difference is now we've started issuing the automated external defibrillator without the X on the end. And what this is you attach it to the chest. Well, don't attach it. You go to examine patient and you check rhythm, and then it'll verbally tell you if you need to shock it. And this prevents you from leaving your AED behind because it's kept in your inventory during the whole process. You don't attach it to someone else. There's no annoying beeping. The only thing is you lose the heart rate and blood pressure monitoring. It still allows you to shock a patient when it's necessary. Obviously, I'm awake, so it's not letting me shock myself. The pulse ox, that's applied to the hands, and I think it lets you do it on the legs. Nope, just the hands. So you can attach a pulse ox, and let me go ahead and do that. That'll allow you to monitor the heart rate and SpO2, which is updated about every second, so it's pretty constant monitoring there. The next resource people don't often cover is, well, people. Your teammates are one of your greatest assets on the battlefield. They can provide you covering fire, deploy smoke, call in a medevac, or with your direction, assist in rendering aid. When you're getting assistance from teammates, make sure to give specific instructions on what would help you most, keeping in mind that your teammates aren't usually medics and won't have all the medical items necessary to help you. So people, they're just helpful, okay? Most players aren't super nerds when it comes to the medical system, so if you need them to do CPR, for example, tell them that's what you need. If you need them to do a bunch of head turning, tell them that's what you need. On to the treatment procedure. So in Arma, the BBB treatment procedure is one we should follow. Generally, don't use this IRL. It's not for IRL. Bleeding, breathing, and beating is the order in which we go, with some exceptions between these two. And that's because if you have no heart rate, obviously your lungs are not functioning, and so you have to skip and go to the beating and then come back to the breathing. Bleeding is the first B in the BBB treatment procedure. There are 3 ways to currently treat bleeding. The tourniquet takes roughly 7 seconds and will completely prevent bleeding on a limb. Natural blood clotting, if you have that turned on, will slowly bandage a patient. And that effect can be enhanced with TXA. If you have blood clotting off, TXA acts as the blood clotting. Bandages are used to directly stop bleeding. So here we have an efficacy chart for each type of bandage. Never bring basic bandages, they're dog shit. I would always advise people to bring the elastic or the packing bandages, and if you have space, grab a quick clot. When we talk about effectiveness in game, elastic bandages and packing are where it's at, because what they deal with is velocity wounds and puncture wounds. Velocity and punctures, I'm sure you can imagine what a bullet does to someone. It has high velocity and it punctures them. So packing and elastic are what you use to deal with velocity and puncture. Quick clot is your run-of-the-mill one, and generally you apply it as the last bandage in the sequence, because what it has that's very special is it is almost impossible to reopen that wound after you've applied quick clot to it. So that's the efficacy. Don't bring basic bandages. So here's let's zoom into that. Here's a chart of the reopening coefficients. So you can see the reopening chances here, as well as the rough timetable. And as you can see, quick clot wins out on that in everything basically. All right, 100%. So yeah, here's what it says here. Quick clot, all of those, just yeah. So next we move on to breathing. Most important thing to know about breathing is that no matter how much work you do treating throat closures and tension slash hemothoraxes, blood O2 will continuously drop when in cardiac arrest. So that's what I was talking about earlier. If you have a patient in cardiac arrest, you treat that first, simply because they will not be able to breathe until their heart is functioning. So when we talk about breathing, there's 2 ways to stop that in game when you are shot, and that's with throat closures or lung issues. So the throat, there are a couple issues there that can happen. Occlusions require medical suction to efficiently clear. Head turning will also work eventually. Obstructions may also be cleared by medical suction, but head turning is more effective. Generally, let me go ahead and use some tricks here to myself. So if we knock myself out and remote control my guy, we come here, head turning under airway management. You're just gonna want to spam that. Generally leave that to someone that's not a medical guy to do, just to maintain that airway. And yeah, that's how you manage the airway as a non-medic. Let me get healed up here. Excellent. Come on. Alright. So King LTs, those are the most effective way to prevent both occlusions and obstructions, and that should be the first step when you're dealing with the breathing step to prevent further closure of the airway. And in all bold and red highlighter, King LTs will not work if the throat is currently blocked. So make sure you clear the airway and then apply the King LT. Generally, you're always going to want to have a King LT in a patient you're treating. So that is an unconscious patient. So here we go on to the more advanced lung injuries that require a stethoscope to listen to. So the tension pneumothorax results when air is trapped in the chest cavity. This creates positive pressure, and it makes it difficult for the lungs of a patient to fill with air. You can diagnose this with a stethoscope, or you can diagnose it with excessively low O2 on a conscious patient. So conscious patients cannot have airway issues as of ACE, whatever version we're on. And so if someone has low O2 and are conscious, that means they likely have some sort of lung issue and would require further diagnosis with a stethoscope. So let's go ahead and listen to an audio example here. Cool. And if we go and look at the treatment options, the first treatment is to use a chest seal. These are vented chest covers that allow for air to come out of the cavity when someone breathes in, and they disallow air from coming into the cavity. This eventually treats that positive pressure issue. Needle decompression, this uses the ACE kit to decompress the air out of the chest cavity. This should always generally be used after a chest seal if the chest seal fails to resolve the injury. Alright, moving on to the hemothorax. The hemothorax is when blood collects between the chest wall and the lungs. This prevents full expansion of the lungs when the patient breathes in. Again, same diagnosis procedure. So if we go ahead and grab a audio example. Excellent. So that's the hemothorax, what it sounds like. My Steam browser has failed. My whole game has failed. Alright, we'll be right back, guys. Looks like we've resolved the issue there. So the way you treat that, ignore what it says here. You cannot treat it with a chest seal. That was probably a copy-paste error, and will be fixed. The only way to treat a hemothorax is by draining fluid. It gets the blood out of the chest cavity and allows you to breathe properly. Alright, moving on to circulation. Circulation refers to the pumping of blood throughout the bloodstream. So that's your heart, that's your veins, that's all that shit. In Arma, only the heart is what we matter about, what we care about. So this is the treatment procedure we've come up with. You don't need to follow this to the letter, but so you determine cardiac arrest. That means heart rate is showing 0. If you're in an emergency situation, you're being shot at, you know, you're being fucked up, and you determine if it's shockable. Again, grab your thing, your AED, check rhythm. If it tells you to shock, you shock. If it tells you not to shock, you do CPR. If it's not shockable, do 2 rounds of EpiPens, do 2 CPR, check heart rate, and see if it's successful. If it's not, just do CPR again, check heart rate, CPR, and so on and so forth. If it's shockable, generally a shock gets it back first try or the second try. If it's a non-emergency, obviously we're just going to use less drugs. That's so as not to waste medical equipment. So you shock, it works, cool, or no, you use an EpiPen and then do 3 rounds of CPR and check heart rate. Generally get non-medical people to do the CPR for you. You know, you don't want to be wasting your time if you're the only medic in a squad of 8 people doing CPR. It's wasteful. Alright, so we have a full treating a patient procedure here, and I've heard people say this is confusing. I don't personally find it so, but we're going to go through it together so you can understand what it says here. So you come across a conscious patient, they've asked for treatment, you go ahead and assess them. Step 1 is to check for massive bleeding and to attach a pulse oximeter. If there is a massive bleeding, start an IV, push TXA, and then start appropriately sized saline. If there's not massive bleeding, then move on to the next step. Next step, if there's not massive bleeding, then you check for lower than average blood oxygen level. You will then treat this for tension pneumothorax or hemothorax based on what your stethoscope is telling you. If there's no tension pneumothorax or hemothorax, you move on to the next step, which is to treat minor bleeds with the appropriate bandages. Then you stitch wounds or apply EACA. Then you top off blood level based on the amount of saline and amount of blood loss. Then you treat any pain. So those are generally the steps when you come across a conscious patient. There's not much more to it. Unconscious patient, a little bit more involved. During all steps of the process, you're going to want to make sure that any new bleeding is being dealt with in a timely manner. You don't want wounds reopening on you. So generally start an IV and then push TXA, then saline. The saline should be appropriately sized for the amount of blood loss. Generally, if someone is unconscious, they've just been shot and possibly been sitting there for a while. Saline lets you have less of a rush to bandage any wounds, just because it'll act in a way that sustains the life of a person who has blood loss, basically. Then tourniquet bleeding limbs or bandage chest/head, depending on where the heaviest bleeding is present. Optionally, you can then push EACA to stitch wounds while you're doing the rest of your work. You can attach a pulse ox to diagnose blood O2 and heart rate at the same time. Then you check if the throat is clear. If it is clear, apply a KLT. If the throat isn't clear, you clear the throat and then apply a KLT. If there's no pulse, then you start the cardiac arrest procedure. If there is a pulse, then we're going to use the wake-up cocktail here, which we'll go into more detail later, but it's adenosine, epinephrine, and painkiller, which quickly wakes your patient up. And you move to step 1.5 of the conscious patient procedure. Next, we have a little note about determining death. The most certain way to determine if a patient has died is when a patient is unable to be carried or dragged. Do not treat a patient as dead until they are determined dead by this method. Often you're going to want to have two people verify that a patient has died, and most servers won't allow you to additionally put them in a body bag until they've died. So those are your two methods of determining that. As we can see, I'm conscious. So it doesn't show up here, but if I was unconscious and this was grayed out and I was making sure I selected the torso, that means that this guy would be dead. Next, we're going to talk about triage. So triage is the practice of assigning levels of urgency to multiple patients when you're dealing with more than one patient. If two patients have similar injuries, you should follow the triage order. It is important to note that if a command staff is conscious and combat effective, you should first deal with any unconscious patient, no matter how low in the triage order they are. So, in units, often command staff will bully medics into treating them before an unconscious patient. Try to ignore that bullying. If the unconscious patient dies, that's on you and the command staff person at that point, if they successfully bullied you into treating them. Oftentimes they're just being a little bitch, so move on to the unconscious guy. So as we talked about at the start, in a triage situation, it is recommended to use TXA on every unconscious patient, no matter what level of triage they are. This will temporarily prevent the situation from getting worse by closing wounds of multiple patients without requiring your attention. So here we have the triage order, so command staff / SARCs, which SARCs are medic. So if a command guy is down and a SARC is down, go for the medic first. Medics allow you to spread out more treatment, or they could even help you get the command guy up faster. Then you move on to the element leader, squad leader, whoever that is in your group. Then auto riflemen, this is because they can effectively provide covering fire for you. They can lay down a hailstorm of bullets to prevent enemy from moving onto your position. And then you move on to everyone else. The auto rifleman could be swapped out for a GL guy if you know your GL is effective, and this is based on what the range of the threat is. Or like an AT guy if a tank is bearing down on you, that kind of thing. Next, we're going to talk about risk prevention. A medic should never put themselves at excessive risk to treat a conscious or unconscious patient. So basically, don't run out into the open if a guy just went unconscious. Oftentimes you do have maybe a minute or two to actually formulate a plan and get to them before things get really bad. So yeah, don't just run into bullets to pick up the guy that just dropped. Because obviously if he just dropped, that means there's probably still a threat. So as a medic, cover or concealment is important when you're rendering aid. And cover should always be preferred over concealment. Cover is something like a rock, a concrete wall, or anything that can stop bullets. Concealment is something that visually protects a medic from being spotted. Smoke grenades are generally used as portable concealment. Grab like 6 white smokes. You guys, feel free to spam these things, you know. Guy goes down, smoke. 2 guys go down, 2 smokes, you know. Spam smokes like it's painkillers, okay? Digging trenches, that's your portable cover, so obviously dig a trench when you have the opportunity to dig a trench. So here we go into deciding when it's appropriate to move a patient. So we have the performing immediate treatment at their location while under fire. So advantages of this is you can provide immediate treatment, which can eliminate the possibility of racing against bleed out. Once you've treated him and he's conscious, you both can return to the friendly forces while you're under both cover and concealment, if possible, such as trenches or smokes or, you know, a valley or something. Disadvantages, if there's some sort of heavy medical issue and you require more people to render aid, and it's more difficult for you to request them since you also have to provide covering fire generally for more guys to advance towards your position. This can also endanger the lives of other people approaching you to help you treat. And 1 unconscious Marine is better than 2. So yeah, don't have 2 guys go down just for the hell of it. Hostile forces may also find it easier to advance on your position. That's kind of obvious there. So if you're out in front of your friendlies treating a guy, then the enemies could get closer to you. So the advantages of performing a carry/drag action towards friendly forces are that once you've returned, you can request assistance to treat the wounded, and this will generally have a lower chance of endangering more lives. You are at less threat from hostiles that are shooting at you or advancing on your position. And the disadvantages, if you are not immediately treating the guy at his position, you could be racing against the bleed out issue. And if you're carrying someone, you're once again risking your life and the wounded guy's life while you're moving them and under fire. Some other scenarios that have popped up in my unit enough to put notes here. So in an active combat setting, when you're with your team and being informed that the team needs to move to exfil or exit the area, moving the patient should be of high priority, in some cases taking precedence over the patient health. This is because it will prevent further injury of the entire team, such as you're about to get murdered. Get the hell out of there. If you stay there to treat that one guy, you know there's going to be people in your squad that want to stick by you because you're the medic. And if they stick by you, then you have 4 people down. You're treating the guy and 2 people are covering you, and the guy that's down, you just got murdered and now you're all dead. Congrats. So you're going to want to move that guy if people tell you it's time to move. And when a vehicle is placed nearby the injury and the... let me reread that. When a vehicle is nearby, placing the injury and the medic in the vehicle will allow the team to stay mobile and keep the medic and casualty protected. So in Arma, placing someone unconscious in a vehicle is really simple. If I get myself an off-road here, not with a guy in it, not with a guy in it, holy cow. I get myself a guy, and I toggle him unconscious, and I come over to him. You can see loading is literally instant, and it has quite a bit of range. Once he's loaded into the car, just hop in the car and treat him. It's really simple. It's really handy. Don't sit next to a Humvee or you know, Mat V or whatever you guys are using and just stare at the guy on the ground. You know, put him in the car, get in the car. You're more protected. Some vitals that are recommended before you move a patient. These are just recommendations. So any heart rate present, that's good. Every O2 point above 70 should generally allow you to move the patient about 3 meters. Bleeding, minor to intermediate bleeding should be fine as long as TXA is administered before the move. And there's some pre-movement procedures here to go over. So if time allows, the following steps should be followed before moving a patient. You're going to want to start an IV, push TXA. If they're unconscious and the throat is already clear, insert a King LT. Then deploy smoke grenades to conceal movement and radio friendlies to provide covering fire. This will give you the maximum chance of surviving while you move that patient. I'm just going to scroll down to comms. We're not going to do comms in this because they are not universal between units. So that's the medical guide. We're going to move on to some auxiliary material here, which is the cheat sheet that we've created. You can see we have all these things as well as characteristic sounds of the hemo and pneumothoraxes. We have heart rate and blood pressure stats. We have common treatments. We have some wake-up statistics. And the treatment procedure for bandaging someone. So we're going to talk about that wake-up cocktail now. The wake-up cocktail basically is a way of quickly waking up a patient who has fallen unconscious for whatever reason. And the stats that are generally required to do that, the stats that you want to what you're trying to do when you use the wake-up cocktail is get their is to stabilize their heart rate, their blood pressure, and just increase their wake-up chance. So to do this, as we saw with the charts, is when you inject adenosine and epinephrine, they each add and subtract 20 heart rate. So injecting them together has negligible effects on the heart rate of a patient or their blood pressure. Whereas if we go back to the SART guide and we go to the equipment table, the epinephrine has an increased wake-up chance modifier, which is set by your server admin. Whatever the modifier is set at, that's obviously an advantage. So if you have an unconscious patient, you hit them with an EpiPen and adenosine, you've given them the wake-up modifier without affecting their heart rate in any significant way. And the painkillers, which you additionally give to them, there is such a thing as being knocked unconscious due to pain, such as what we talked about with the fast IO. And the painkillers are there just to provide some pain-killing effect in case it's a pain knockout, which the 3 of those combined should wake them up. Next, we're going to talk about controlling the heart rate of a patient. So with adenosine and epinephrine, you can pretty closely control the heart rate of a patient, at least in a manner that is effective to getting them where you want them to be. So if I go ahead and shoot myself a little bit. Okay, that fully killed me. That was not what I wanted. And I don't have keep loadout on. Awesome. Alright. So let's just go over it with a live dude. Alright. So we'll just pretend. So say he's knocked out. We have a heart rate of about 150. Let me give some epinephrine just to simulate that real quick. So we have a guy with a high as fuck heart rate because you just resuscitated him from the edge of death. So the way to control heart rate, basically, hit him with an adenosine or 2, that'll drop his heart rate down to the range that you can actually go to medication here on his head. And at that point, you can either slap him awake, which in the game is called reorientation, or you can use the spelling salts, the carbonate. And through using various combinations of epinephrine and adenosine, you're going to want to control that heart rate to the point where you can use those abilities. So if we go to wake up stats, this is for the slap specifically. The heart rate between 70 and 100, as well as a good blood pressure, a good O2, and a good blood level will allow you to instantly wake someone up by reorienting them. I think that is everything there is to cover when it comes to being a medic. I don't really think there's much else to add to it. So yeah, I hope you guys enjoyed this sort of long tutorial, or sort of long reading. There are going to be resources posted in the description which you can feel free to use. So yeah, I will catch you guys later.